Okay, thanks. Let's try to get started on the fourth and final session of the day. It's been a terrific day. For me, it is really exciting to be covering healthcare policy in an event like this, given how important it is and how much policy is changing and how much work we're all doing here. Before I introduce the panelists for our fourth and final session of the day, I just want to thank the staff here at SIEPR who have done an incredible job in doing everything, from start to finish, the video, the slides, the room, organizing with all of you, registering everyone, the food, and so forth. So the team here is consisted of Ellen, George, Sean, Hector, Jessica, Heidi, and Bella. So please join me in thanking our outstanding SIEPR staff. And now I'm really pleased, just delighted to introduce our panelists for the final session of the day, where we're going to think about the effects of the ACA at the national level, and two people with a huge amount of expertise in this area. So first, Kate Bundorf, who's a professor here of health research and policy at our School of Medicine. She's been at Stanford since receiving her PhD in 2000 from the University of Pennsylvania's Wharton School of Business. Her list of achievements is long and diverse, and I'm just going to sample a few of them here. She serves on the editorial board of many leading journals in health economics, such as the Journal of Health Economics and Health Services Research. She's a member of the panel of healthcare advisors for the Congressional Budget Office in Washington, D.C., and she's a research associate at the National Bureau of Economic Research. She's a winner of the National Institute for Healthcare Management's Healthcare Research Award, and she was a Fulbright Scholar at the Fudan University School of Public Health. She's done important policy-relevant research on many aspects of our healthcare system and health insurance. And perhaps most important of all, she's a senior fellow here at SIEPR and a member of our faculty steering committee. And so sort of as a member of the steering committee, sort of, I guess technically in some respects, my boss. So it is, so we really like Kate. We're all gonna be nice, Kate. Larry Levitt is the senior vice president for special initiatives at the Kaiser Family Foundation and the senior advisor to the president of the foundation. Among other duties, he is the co-executive director of their program for the study of health reform and private insurance. He previously was editor-in-chief of kaisernetwork.org, their online health policy news and information service, and he directed the foundation's communications and online activities and its changing healthcare marketplace project. Before joining KFF, he served as the senior health policy advisor to the White House and the Department of Health and Human Services, working on the development of President Clinton's Health Security Act and other health policy initiatives. And before that, he worked with California's insurance commissioner, he worked with Kaiser Permanente, and in a number of positions in Massachusetts state government. He holds a bachelor's degree in economics from the University of California at Berkeley. Yes, that is a lot of Cal today. And a master's degree, I know Greg's very happy about that, and a master's degree in public policy from that Harvard's Kennedy School of Government. So please join me in welcoming our two panelists who are going to kick off our session, the impact of the Affordable Care Act at the national level.
Okay, I think the best thing that has happened to me today is I've become Mark's boss, right? And I'm very excited about that. So what I thought I would do in this session is I would talk basically about three things. So first, I want to talk a little bit about, you probably have a sense that the ACA is incredibly complicated, and I'm going to talk a little bit about why I think the legislation is so complicated. The second thing I wanted to do was talk a little bit about what are these key policy controversies that people have been talking about for the last few years, and then give some evidence on some of them, the extent to which the concerns we've had have come to pass or have not come to pass, et cetera. And then the final thing I wanted to do is just, is look at the data. It's still, this is actually a really exciting time in the ACA in the sense that all these things that we've been talking about for the last 4, 5, 6 years are starting, the evidence is starting to come in, right? So the data is starting to come out and we can kind of see what's happening. Okay, so it was a very complex piece of legislation and I'm going to boil it down to 4 bullet points for you. So what did the ACA do? So in my mind, the ACA, the key feature or the key thing the ACA did was it was an insurance coverage expansion, right? So it expanded insurance coverage, mostly for working age adults, to a certain degree for kids. But prior to the ACA, as probably most people know, there was a large uninsured population, and the ACA was an insurance coverage expansion. There's a lot of talk around these issues of cost associated with the ACA, but when you look in the legislation, The ACA didn't have these very direct kind of cost control measures. In my mind, what the ACA was kind of a series of mechanisms that we're going to kind of try out to see what works. And you can see a lot of that in the context of the Medicare program. So the government has control over the Medicare program and can make rules and change it more easily than it can maybe change private insurers. But you see things like the CMS Innovation Center, where the idea was, well, we don't know exactly what is going to reduce healthcare spending, and we certainly don't know how to do it in ways that promote efficient care. So let's try a bunch of stuff in the Medicare program, and then we'll see what works, and then we'll try to disseminate that more broadly. I think another key feature of the way the legislation was passed is essentially it was required to be deficit reducing. This was because the legislation was passed through a special mechanism that made it easier to pass and only needed a simple majority. But the requirement was, any money that went out, we had to reduce government spending correspondingly. So if you look at that first bullet point, you say we're going to expand insurance coverage. That's going to be expensive from the government's perspective. We're going to have to give subsidies. We're going to have to help people buy health insurance, since we know health care is very expensive. That's a bunch of money going out. For every dollar that goes out, a dollar has to be cut in terms of government spending. So how did we do it? We were expanding insurance coverage. There weren't very many direct cost control mechanisms. Well, how was the ACA financed at the end of the day? I think it was financed primarily by tax increases, and then, as a couple of the speakers have alluded to, reductions in payments to Medicare providers specifically. Okay, so I think from the previous slides, you have a sense of the coverage expansion was very complicated. There's a bunch of stuff going on in terms of Medicaid expansion and health insurance exchanges and people at different poverty levels and cost-sharing subsidies and risk adjustment and Here's why I think that was. So if you look at this picture, basically what I've plotted here is the number of people who fall in different insurance categories by income. And if you go across the four categories in the bottom, there's a key point in each of them. So if you look at the people who are uninsured, I think, and we're going back to 2010, I should make that clear. So if we look at the people who are uninsured, in 2010, I think we think of uninsurance as something that happens to low-income people, and that's certainly true, that low-income people are more likely to be uninsured. But when you look across the income distribution, there were uninsured people at all levels of income, right? So there are uninsured people who are low income, medium income, high income. You can quibble with the way that I've defined low, medium, and high income, but the general point is there are people who lacked insurance at all these different levels of income. Okay, so that is complicated, right? So we can't just target new health insurance to very poor people because we'll miss a bunch of the uninsured. And if our goal is to reduce the number of uninsured, that's a problem. The second category is also important. So these are the people with employment-based coverage. As you can tell, those bars are very tall, especially that means there's a lot of people there, especially for medium and high-income people. So this is important for the design of the legislation for two reasons. The first reason, and I think it was Don Barr that talked a little bit about this in his question. Those people have health insurance and they tended to like it, right? So if you ask, there was actually much of the data that I'll be focusing on today comes from the Kaiser Family Foundation, which is Larry, our next speaker, works with a lot of that data. But there were Kaiser polls at that time, asking people, do you like your health insurance? Are you satisfied with it? And maybe like 90% of people would say, I'm satisfied or really satisfied with my coverage. Messing with provider health insurance was a huge problem for the Clinton administration when they tried to pass health care reform, right? So you want to cover those uninsured people, but you want to avoid that huge mass of people in the middle who have employer-sponsored health insurance in the sense that you don't want to threaten their coverage because you'll lose public support. The other issue with employer-sponsored health insurance is a lot of those people they have health insurance and they pay for it through lower wages. So if you shift them into getting health insurance through a subsidy, now you've increased the cost to the government of the health insurance expansion. And I just told you in the last slide that that's hard, right? Because every time I give someone else a subsidy, I have to raise some revenue or cut some spending somewhere else. So that's another reason why, if you were expanding coverage, you want to avoid the folks with employer-sponsored coverage. You want to keep them in their coverage. Direct purchase, those are people who buy it individually. We've talked a little bit about that today. Prior to the ACAs, you can see there weren't that many people who bought their health insurance on their own. The size of those bars are actually a little inflated for various reasons. when people looked at that, I think before the ACA, most people looked at that market and said, this market is not functioning very well. There were differences of opinion in why it wasn't functioning well. Some people thought individual insurance is just inherently doomed and it's just not going to work. Other people thought, well, everyone has employment-based health insurance. Individual insurance is kind of this residual market. Of course, it doesn't work. You're only there when you're sick and you don't have a job and whatnot. But we didn't have a robust functioning individual health insurance market. The last group is government health insurance. This includes people age 65 and over. If I didn't have those folks in this graph, then I'd have most people with government health insurance would be low-income folks, but government publicly financed health insurance didn't, as we've heard, cover all low-income folks. Okay, so there's this very heterogeneous set of uninsured. You don't want to mess with employer-sponsored coverage. What did the ACA do? Well, the ACA has a set of policies that are trying to avoid the employer-sponsored coverage, eroding that, extending coverage to more people. What are those policies? We've already talked a little bit about this, so I'll go through it quickly. We have an individual mandate, a requirement that people buy health insurance or they pay a fine, the Medicaid expansion for very low-income folks, a set of subsidies for kind of high-ish, low-income and middle-income folks to purchase private health insurance in health insurance exchanges. And then John Burko did this brilliantly. We had a lot of insurance market reform. The insurance market reform, I think many people didn't realize, at least at the beginning, that the insurance market reform was not only in the exchange, but it was outside the exchanges. You can still buy health insurance outside the exchanges, and most of those rules will apply in any setting. Those are all things that make people buy health insurance and often publicly subsidize health insurance. So to complement those, there are some employer penalties for employers who don't provide affordable coverage or drop health insurance for their workers. And the idea there was, to try to keep employers offering health insurance. Okay, so a number of things happened along the way, the best laid plans. So what happened with the individual mandate? Probably most people know that there was a constitutional challenge to the individual mandate. It was upheld primarily based on the idea that it actually, at the end of the day, was a tax. That was a little ironic because the Obama administration spent most of the reform period leading up to the reform saying it was not a tax, it's not a tax, and then at the end of the day, it was kind of good for them that it was a tax. This is probably the most used slide in health policy right now. You've already seen this at least once today, maybe twice, I don't know. So now you know, Medicaid. The individual mandate went through, and I think as Jay explained completely, what the big surprise was the Medicaid expansion, right? So the idea was that all states would expand Medicaid. It turned out that the court ruling allowed states to opt out of Medicaid. I'm not going to talk about the Cadillac tax because I'm running out of time. Okay, so what are the key economic and policy questions? So first of all, we kind of want to know how much did the ACA increase coverage, insurance coverage? This wasn't obvious in the beginning for at least two reasons. So one is we need to know how responsive people are, the insured in particular, to the penalties and the subsidies created by the ACA. And then the other big controversy that people argued a lot about was, will employers choose to drop health insurance? And it's really kind of a complicated question, right? Because a lot of people have health insurance, but then we're giving subsidies, in many cases very large subsidies, to low-income people. This creates a tension because low-income folks and even up to middle-income folks, in some ways, they'd be better off getting their subsidized coverage and getting a subsidy from the government rather than getting their health insurance through an employer. So this creates a tension on employers. Should they offer health insurance to their employees, or should they create an opportunity for their employees to go get health insurance in the exchanges with a subsidy? And prior, there have been a number of studies that have had very different conclusions. Some people say, yes, there's going to be a lot of dropping. Some folks said, no, that's not going to happen very much. Okay, another controversy I'll give you some data on as well is, that we argue a lot about, well, did the ACA slow the rate of growth of healthcare spending? I'll come back to that. And then the third issue that I think is important is, did the income-based subsidies affect labor market participation? This is very important because when you think about the way the subsidies are structured, very low-income people, they get all their health insurance paid for, but the subsidies phase out at 4 times poverty level. So that's a big change in the amount of subsidy you're getting as you earn more income. That creates potentially negative incentives for folks to work. Okay, so what is the data that we have so far? So I'm going to focus on data from the current population survey. If we plot, the proportion of people uninsured over time, it's hovering just under 16%. As we can see in 2013 and 2014, with the introduction of the exchanges and the subsidies and the Medicaid expansion, we finally see a drop in the proportion of people who are uninsured. The 2015 data is out from the National Health Interview Survey. It's a different data source. And Larry's going to give you that one, so you just have to hang on for about 3 more minutes, and you'll have the final data point, or the most recent data point. Okay, so I think this is a very interesting slide. So what's going on here? So basically, in this slide, we're looking at the expansion states and the non-expansion states, those that expanded Medicaid and those that didn't expand Medicaid. And then we're looking at health insurance rates of coverage in 2013 and 2014 by income level. So when you look at the expansion states, you see basically what you'd expect, right? For these very low-income folks, rates of uninsurance are declining pretty dramatically. There are declines for middle and higher income people, but they aren't as large. If you go over here to the non-expansion states, you see a much smaller decline in the proportion of especially these low-income folks who were uninsured. It's actually interesting that there is a decline, right? So these are very low-income people, and there was a decline in the number of uninsured. One mechanism for this could potentially be what people call the woodwork effect, right? So now that there was this new government program in place, people went to an exchange, they tried to figure out whether they would qualify for coverage, and it turned out that they actually would have qualified under the old rules for Medicaid, and they end up getting health insurance, even though they didn't qualify as part of the expansion population. If I take those 2 bars and compare, I can kind of do a simple analysis and say, well, it looks like, if this was all, in the non-expansion states, if this was all a woodwork effect, then maybe if these states are similar, I might estimate that maybe about half of, this decline, maybe a little less than half, is actually a woodwork effect as well. A study just came out by John Gruber using this data where he estimates that roughly half of it is a woodwork effect, right? So, so we have maybe some evidence that that's true. Oh, I do have to say though, if you look at the National Health Interview Survey, you don't see that dynamic, so it's a little bit up in the air. The other controversy that I talked about is the declines in employer-sponsored coverage. This just gives you the change. I focus you over on the right of this page. It gives you the change in coverage for different types of coverage. The thing to focus on here is basically looking at employment-based coverage, right? So we were really worried that employers would stop offering coverage to folks, or people would end up in jobs that didn't have employment-based coverage. At least 1 year out, we see very little effect on the proportion of people in employment-based plans, right? So far, employment-based coverage seems to be pretty stable, and we'll have to watch that as we go forward. Another controversial thing that folks talked about was, it turned out when the ACA was, during the period of adoption for the ACA, healthcare spending, the rate of growth in healthcare spending declined, right? So healthcare expenditures weren't growing quite as fast as they used to be. It happened to about coincide with the introduction of the ACA. The $100,000 question, or bigger than that, question is, was it the ACA or wasn't it? Right? My read of the literature is it shows that maybe about half of the decline in the rate of growth of healthcare expenditures can be explained by things like the economy, the worsening economic conditions, the recession, declines in the generosity of employer-sponsored health insurance, but the rest of it is still kind of unexplained. I should have hid that last bar before I gave this picture to you. But basically, if we look at the historical growth rate, it was about 5%. In 2009, 10, 11, 12, 13, it had slowed down. I think that we're seeing a pickup now in the rate of growth of healthcare spending. And to me, that implies that even if this was driven by the ACA, it doesn't look to date that it was a serious kind of structural change in the rate of growth of healthcare spending. The last thing I want to say is how much did this cost the government? The CBO just released a report in March of this year, and the folks at the CBO basically estimated that the coverage provisions of the ACA increased government spending by $110 billion, reduced the number of uninsured by about 22 million. What does that mean for the cost per newly insured person? About $5,000. Is that high or low? To me, it sounds like, for each person who's newly insured, we're basically paying for almost all of it, through government spending. If we'd had a huge amount of crowd out, that number would have been much higher, right? So I guess it's whether it's high or low depends on how you look at it. I'm going to skip over that since I'm out of time. Looking forward, what do I think is going to happen? I do not like to predict the future. But I'll make a couple comments here. I think if we look at, is uninsurance likely to continue to decline? The only mechanism by which I think that would happen in a substantial way is through additional states expanding Medicaid. Erosion in employment-based coverage, I tend to be in the camp where there might be some, but I don't think it's dramatic. High-income people still get big subsidies by buying health insurance through their employer, and I think employers are likely to continue to offer. The employment effects, I think we have very little evidence on the employment effects. Most of the evidence we have is from simulations or guesses. So we'll have to keep watching those. I think it would take a while for those employment effects to manifest themselves. And in terms of the rate of healthcare spending growth, will it increase? I have to say, I think it's going back up, but your guess is probably as good as mine.
I generally describe my career as one of designing failed healthcare reform plans, from Dukakis in Massachusetts to first Clinton, California. So I left government and the Affordable Care Act passed. So clearly the common denominator. I also, as a health policy person, I tend to define the glass as half empty, but I'm going to start with the half full part of the glass. And Kate talked about the trends in uninsurance. This goes back, we've actually compiled the data back 4 decades. And it's quite dramatic. 2015, and this data actually just came out this week. The uninsured rate is down to a little over 10% for non-elderly people and under 10% for the whole population, which is the lowest rate it's been in 4 decades. And you can see the sharp downturn since the Affordable Care Act passed. It's very clear that it's due to the ACA. So I would say the main aim of the ACA was to expand insurance coverage, which Kate talked about, and it has certainly been a success at doing that. Amir talked earlier about the marketplaces, which are kind of one of the 2 main mechanisms which the ACA has expanded coverage, the other being Medicaid. And since healthcare.gov melted down, there's been this incredible focus on how many people are enrolling in the marketplaces. And as Amir said, the expectations, it has fallen short of expectation. By this point, the Congressional Budget Office, which is kind of the referee of all numbers in Washington, expected over 20 million people to be enrolled in the marketplaces. And you can see in the first year, in 2014, it was 8 million, climbed to 11.7 million at the end of open enrollment last year, and to 12.7 million at the end of open enrollment this year, so well short of 20 million. And even these numbers are a little inflated because they are people who signed up. Not all those people actually pay their premiums and get insured, so you need to subtract about 10% from this. So still fallen well short of expectations, and there are a couple reasons for that. One is, as Kate talked about, employers have not dropped insurance in the numbers that people expected. So there was this expectation that employers would drop insurance and those workers would end up in the marketplaces. That largely hasn't happened. Also, there was a controversy as the ACA was starting up with people getting their plans canceled because they didn't comply with the ACA. The administration kind of freaked out about this and decided, no, you can keep your plans. So that also depressed enrollment in the marketplaces because people were keeping their old plans, which they're allowed to do until the end of next year. So kind of what might happen in the future. I also don't like to predict the future, but there is definitely room for growth here. One thing we did is we looked at the top 10 states, and I'll go through some of these numbers, and how they're performing in terms of enrolling people. And if all states perform like those top 10 states, enrollment would hit 16 million. I think there's no way we're going to hit the 20 million, over 20 million that the Congressional Budget Office predicted, but there's still definitely some room for growth. So if you look at that variation, it is tremendous across states. Obviously, states vary a lot in population, so we've tried to normalize this by looking at what share of the potential market is actually enrolling. And the potential market includes people who don't have coverage through an employer, who either are already buying their own insurance or are uninsured and are not undocumented immigrants who are not eligible to enroll. And as you can see, I mean, the variation is massive, from under a quarter of the potential market enrolled in Iowa to over 2/3 in a number of states. California is just kind of below the top 4 here. This isn't a great measure because, as I said, this potential market includes people who are already buying their own insurance. They just may be buying it outside the marketplace. We sort of don't care so much about those people. They're at least insured. So a different way of looking at it is to look at people who are eligible for those subsidies. So these are the people between poverty and 4 times poverty who are actually eligible for help by enrolling in the marketplaces. And we looked at the variation in how many are eligible and how many are signing up. Lo and behold, in Florida and Massachusetts, more people have signed up than are eligible, which they're not manufacturing, enrollees like Chicago manufactures voters. But what's kind of going on here is, number one, these are estimates. So there's some statistical error attached to them. Also, some of these enrollees, as I said, haven't paid their premiums, so they're not actually enrolled. So that will drop down a little bit. But I think it's fair to say that in a number of states, enrollment is pretty much maxed out amongst these low and middle income people who are eligible for subsidies. There's room for growth in states below the average, but in certainly the top 5 to 10 states, there's, and I would include California in that, there's very little room for additional enrollment. So the question is, who's left among the uninsured out there? And this is data as of early 2015, so it's changed a little bit, but it hasn't changed a lot. There are roughly 30 million uninsured still out there. So the ACA has accomplished a tremendous amount in reducing that number, but there are still 30 million people who are uninsured. So who are they? Well, about half of them are actually not eligible for any help under the ACA. Their income is too high to get subsidies, so their income is over 4 times the poverty level, or they have an offer of employer coverage, which makes them ineligible for subsidies. About 5 million are undocumented immigrants and uninsured, so again, are ineligible for help. And about 3 million are in that gap in those states that have not expanded Medicaid. So these are people under poverty, very poor, can't possibly afford their own insurance, but their state has chosen not to expand Medicaid. The other half are eligible for help, and so these are the targets for outreach. About half, a little under half, about half of them are tax credit eligible, so these are the targets for the marketplaces, and about half are Medicaid eligible. And this includes people who are newly eligible for Medicaid under the ACA, but it also includes these potential woodworkers that Kate talked about. So people who've been eligible for many years, even before the ACA, but just haven't signed up. So I'll just be very quick here. John talked a lot about the churn, and churn is a very big issue. I mean, think about there's 2 ways to increase enrollment if you're a marketplace. One is to attract new people, the other is to keep the people you already have. And there's just tremendous turnover. If you look, for example, at the end of 2015, there were 8.8 million enrollees nationally in the marketplaces. Of those 8.8, 7.8 stayed, so they lost about 1 million. And then 4.9 million new people enrolled. But that brought them just back up to where it stood at the end of open enrollment in 2015. So you basically got to enroll a whole bunch of people just to stand still. Most of this, as John mentioned, is unavoidable. These are people who have lost their jobs and end up on Medicaid, or have gained better jobs and end up with employer insurance. California actually has the best data of this. Less than 20% of them actually end up uninsured, who are the people you would want to make sure you keep. So we actually just released this survey today. We've been surveying every year. We do a lot of surveys. We survey the public monthly. This is an annual survey we do of people in the non-group market. So these are people in the marketplaces or buying their own coverage outside of the marketplaces. This looks in particular at the marketplace enrollees. And one kind of red flag is that if we ask people, are you satisfied with your coverage, they generally say yes. But if you ask them specifically, are you satisfied with the premium you pay, or are you satisfied with your deductible, that you pay once you have insurance, we're seeing a decline in the number of people who are satisfied. So, in thinking about how you retain enrollees and attract new enrollees, definitely some red flags in terms of people's concerns. I should say that the best predictor of whether someone is satisfied or not is whether they're a Democrat or a Republican. Democrats turn out to be satisfied with their Obamacare coverage. Republicans, in the same circumstances, turn out to be unsatisfied. So you can maybe take some of this with a grain of salt. So looking very quickly, we've talked a lot about the premiums. The deductibles are very substantial in these plans. The plans are standardized into these are what are called metal tiers from bronze, silver, gold, and platinum. If you look at the average deductible in these plans, in a silver plan, which is the most common plan, it's $3,000 a person. So very substantial upfront deductible for people. Now, one important thing to keep in mind is that many of those low-income people are eligible for subsidies. There was a question earlier about the court case challenging those. Those reduce the subsidies for many low-income enrollees. But for someone, if you look at this CSR 73, this is for someone whose income is between 2 and 250% of the poverty level. So still, someone with not a lot of money, they're facing a deductible of $2,500, which is a lot. And to put that in a little bit of context, you have to understand that a lot of people in this economic situation are living paycheck to paycheck and have very few assets to cover a medical emergency. We looked at the assets of people with private insurance, and I'd focus you in on the one, sort of the third bar from the right, which are people between 100 and 250% of poverty, so the low-income people who are very much the target for these marketplaces. They have average liquid assets of $1,400. So you'd have a lot of difficulty covering a deductible of $2,000 or $3,000. This, of course, is not just a marketplace problem. This is looking at people with coverage through large employers, and the deductibles have increased 256% over the last 10 years, far faster than their wages, far faster than what insurers are paying towards their care. It's not surprising that many people have problems paying their medical bills. Certainly the uninsured have problems paying their medical bills, but 20% of people who are insured say they have had a problem paying their medical bills in the last year as well. Again, a combination of people not having much money in the bank and facing ever larger deductibles. So looking ahead, again, back to predicting the future. Increasing enrollment, while challenging, is still key. John talked a little bit about the risk pool. Once the ACA guaranteed insurance to people with pre-existing conditions, people who are sick, they were the first in the door to get insurance because they knew they needed it. The challenge now is to get more and more healthy people to balance them out and keep premiums stable. So increasing enrollment is key to getting those healthier people. Outreach is certainly key to that. If you think back to those churn numbers, outreach is not something that needed to be done just in the first year. It needs to be done every year in order to keep enrolling people. John talked about, and I would just echo, that I think we're in for bigger premium increases in 2017. That does not mean the market is collapsing. It does not mean the ACA is collapsing, but premiums are definitely heading up. And I would just end with kind of the biggest thing looking ahead to the future is an election we're having this year. And I'm happy to answer any questions about this, but just point to a few things that are at stake in the election. Starting from the right, Donald Trump, the presumptive Republican nominee, as every other Republican candidate has proposed repealing the ACA. They've proposed that. I still think that's going to be quite difficult to do. With 20 million more people insured, repealing the law and taking coverage away from those people will be quite difficult. On the other end of the spectrum, Hillary Clinton, the presumable presumptive Democratic nominee, has talked about improving the ACA. Bigger premium subsidies and tax credits for people to help them with their out-of-pocket costs. And Senator Sanders has proposed a single-payer plan, which he has proposed a single-payer plan that would replace the ACA with a government-financed system, which would create an enormous amount of disruption and certainly seems highly unlikely to happen in this political environment. Thank you.
So I'm just going to ask our there was a lot of information there, but as a consequence, we ran a little bit over. So I'm going to take the time primarily for myself, but I'll just ask one question. For each of you, we've talked a lot about coverage expansions and what's happening with costs and so forth throughout the day, and I'm just curious to get your take on a couple of things, whether you think they are important parts of the ACA. The first one is the Cadillac tax, which is slated to take effect, I think, right now in 2020, which would basically, if you have really expensive health insurance, your insurer would then pay a tax to the federal government, and that would sort of encourage people to keep costs below that threshold where that tax starts. So is that, do you think, an important part of what's happening right now in the healthcare system? And then second, there were many changes in the ACA to the Medicare program. There's no expansion of coverage through Medicare, but there were reductions in the rate of growth of reimbursement, which, and there were things injected such as penalties. If you had high readmission rates, then you would not be, the hospital would be reimbursed less. And so I'm just curious, this kind of, and I'll throw out just that broad set of things, this big potential lever for private employment-based insurance, the Cadillac tax, and the various things that are happening to Medicare. Do you view any of those as significant with respect to what's happening to costs now or going forward? So Kate, why don't you start?
So thank you for giving me the time to talk about the slide I skipped. So I think that I think the Cadillac tax is important. I think that the Cadillac tax, I usually don't like to speak for all economists, but I think in this case, most economists generally support the Cadillac tax. The public and politicians hate it, right? So there's a big divergence. I think the Cadillac tax is important for two reasons. One, it raises some revenue, right? So we just expanded coverage, so it's nice to raise a little revenue. The more important reason, though, is the incentives it creates for employer-sponsored insurance. So as you know, there's a very large subsidy for employer-sponsored insurance that makes plans much more generous than they would be otherwise. And the Cadillac tax, I think, is kind of a break on employer-sponsored insurance. Do I think given the public doesn't like it and economists do, I don't feel incredibly optimistic that it's ever going to get passed at the end of the day. In terms of Medicare, I think the changes that are happening in Medicare right now are incredibly important. One reason is because often things that the Medicare program does kind of paves the way for other private insurers. So there might be similar programs or variations on the ways that Medicare is changing payments to providers, and those things could be important. I think it's a time of experimentation, right? I think some of those will take off and stick, and others probably won't.
Well, I would say Kate probably understated the opposition to the Cadillac tax. It's not just non-economists who hate it, it's pretty much everyone.
Do you hate it, Larry?
We don't take a position on policy issues.
Okay.
The problem with the challenge with the Cadillac tax is it was sold as a Cadillac tax, but because of the way it works, it becomes a Chevy tax. Over time, virtually anyone with employer-provided insurance would face that tax, which is what makes it so politically difficult. On the other hand, that is also what makes it a very powerful force for cost containment. I don't think it will ever go into effect, but I think it will precipitate a debate for what to replace it with in terms of containing costs. And potentially replacing the revenue. I mean, it raises, particularly over time, a lot of revenue that was used to fund the subsidies and the Medicaid expansion in the ACA. Speaking of costs, I mean, Medicare, I think it's very underappreciated how much the ACA did to lower the rate of growth in Medicare. I mean, the rate of growth in Medicare on a per capita basis has been close to zero over the last few years. I think partly because of the general slowdown that Kate talked about, but a lot because of the changes in the ACA. And the history of healthcare financing is that changes typically start in Medicare, whether it's DRGs, or potentially now accountable care organizations and bundling, and tend to then spread into the private sector. So I'm hopeful that those changes in Medicare will actually take hold and spread.
Okay, I'm going to open it up for a few questions. I understand that one of my research assistants has raised her hand twice after 2 sessions, and I didn't call on her. So does she have a question after this one? Do you? Okay, Chelsea gets to ask the first question. I'm going to be in trouble with Chelsea if I don't call on her.
So yeah, my name's Chelsea. Yeah, Kate Mark's my boss. It's good to see that there's a woman on the other side who's in charge other than his wife. So
Keep him in line.
I am a sophomore here, and I'm by no means a expert in behavioral or health economics, despite going to Stanford. But my question is perhaps remedial, but I was wondering what the reasoning was behind this abrupt cutoff of subsidies at 400% of the poverty level instead of going for a system such as one in the Social Security disability where they phase out benefits if someone's working or something, for example.
I think that my sense is at the end of the day that the subsidies, there's a general design that the subsidies are going to phase out with income, and at the end of the day, the exact levels that were chosen were really kind of model-driven in the sense of how much are we spending, and then how much are we raising revenue in other areas. So I don't think there was any conscious decision to say 400 is just enough, or we should phase it out this way. It's kind of how much did you have to spend, and how much revenue could you bring in. I don't think there was a real...
I would agree. I mean, there's a process that goes on in any legislative debate where, kind of behind the scenes, where congressional staff put parameters on the table for the legislation. Congressional Budget Office does estimates, and you realize, usually on the first round, you realize you're really far off. So you got to figure out a way to trim the subsidies, which is often easier than raising taxes. I will say Hillary Clinton has proposed lifting that 400% cap, so capping what people have to pay towards health insurance at 8.5% of their income, no matter what their income is.
Yeah, I do want to reinforce that I don't think this is an easy problem. This is kind of a fundamental problem in economics, how you design a subsidy system to kind of minimize the negative effects, but still generate the transfers that you'd like to have.
Christopher.
Just a quick comment. First off, are there increasing or decreasing number of people who start the enrollment process but don't finish? So I understand that's been a big problem, which was making it all the way through to actually getting to where they can sign up and pay. And then the second somewhat related point is, are people getting insurance but really not using it because they can't afford the deductibles? So two different ones. In other words, we have people who either could be covered, aren't making it through, or have it but aren't using it.
There's, for your first question, generally speaking, there appears to be a decreasing percentage of people who are not making it through the whole enrollment process. So that's getting better. In particular, it's getting better. There were a lot of issues in the beginning about people not providing documentation for their income in time and then getting kicked off. That's improved a lot. Hard to say on the second question. It's very early on. It's very difficult to separate some of the pent-up demand that happened initially with people who were sick coming in and getting services that they couldn't get before, and then kind of how that's diminishing over time versus people not actually accessing care. John may.
I'll just I'll add that Covered California has seemed to address your second question, that we would put 3 office visits for primary and generic drugs before the deductible hits, so they have more of a chance. And we were happy to see that the standard plans that the feds have proposed look to do the same thing among those myriads, thousands of other plans with the big deductibles that I think Larry was referring to.
Okay, one more question back here.
Phil Lebhertz, San Mateo. When you have the churn over time, you don't have to have very many people that didn't churn who would have churned except for they were sick. And so I'm wondering about the adverse selection numbers in the pool. It might be a John question, but I mean that's the one that sinks the pools.
Okay, Bella, can you snake? Or Sean? Yeah, sorry, Sean's got it. It looks like
Okay, thanks. Good news so far. We use the California OSHPOD database, if you know what that is, with all the hospital inpatient and ER visits. From 14 to 15, we had almost exactly the same percentage of people with chronic illnesses, but those folks that had chronic illnesses were less intensely sick. And I have just gotten the 2016 cohort. We do this in advance of what the feds do. and it's looking like the churn is actually very, very slightly diminishing the health risk score. Now, actuaries talk about it like that. It's not the average cost or anything. It's how much of a health burden do these people bear. So far so good on the churn in California. I don't know about other states.
Okay. Oh,
I would just add in general, I mean, California has been a model in terms of how the ACA has played out. You know, the number of people who have enrolled, the stability of the market, the premium levels, premium increases. Other states, it's definitely working less well. I mean, the insurance pool is sicker. Premium increases have been higher and likely will be higher in 2017. So it's nice to be in this California bubble, but it's not the way it's working everywhere.
Kate, do you want to add?
No.
Okay, great. Well, with that, we are going to wrap up. So thanks so much to our panelists, to our staff, and to all of you for coming. Have a great weekend, and feel free to come up with any more questions.